Welcome
Okay,
all of you
welcome.
to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Adeeba Albadran from Riyadh, Saudi Arabia. Dr. Albadran is an assistant professor at the Princess Noura bint Abdulrahman University in Riyadh, Saudi Arabia. She's also orthopedic surgery consultant with specialization in shoulder surgery and arthroscopy. After completion of her residency from the Saudi Board in Orthopedic Surgery, affiliated to the Saudi Commission for Health Sciences, she pursued a Canadian fellowship in shoulder surgery at the Western University and another fellowship in upper limb and arthroscopic surgery from the McMaster University in Ontario. She holds a master's in public health, specializing in humanitarian assistance from the Johns Hopkins University, Baltimore. So today it's my great honor to introduce you to Dr. Adeeba Albadran from Riyadh, Saudi Arabia. Over to Adeeba.
Hello, everyone. I would like to thank you, Dr. Gopal and Dr. Al-Khatib, for the invitation. It's my pleasure to be with all of you guys and to talk today about the basics of preoperative planning in shoulder arthroplasty. I have no disclosure for this talk. The preoperative planning is a relatively new concept in shoulder arthroplasty. And back in the days, we used to do a preoperative planning based on the X-rays and also based on later on a CT scan, and we can have a look into the MRI of the patients. By doing a preoperative planning preoperative planning back in the days without any platforms to do that, we used to check for the X-rays on an osteophyte, we checked for the cortical thickening, we checked also for the deformities, we sometimes checked for any deformities and also bone loss. But as you all know, shoulder replacement was mainly based on all of this. But with the advancement of the imaging and with the advancement of the artificial intelligence, nowadays we have the concept of preoperative planning. Mainly, all of the companies nowadays they have the different platform to do the preoperative planning. It's an important tool to have it preoperatively to evaluate if there is any bone loss, to check if there is any anticipated challenges that might happen during the surgeries. And also, by doing the preoperative planning, you can have a clear communication with your company rep to have all of the set available and all of the sizes that you wanted to apply on this patient or you anticipated to apply on this patient beforehand. So you don't have any difficulties intraoperatively. I mentioned that it's a state of art. It's literally a state of art. Once you know the concept or once you know the basics of it, then you can manipulate your concept or also the basics based on each and every case and go ahead with it. I would say 90% of the preoperative planning that was done before the surgery was implemented on the patient, and but there is a percentage that sometimes you cannot do what you plan to do because the preoperative planning, it does not take into consideration the soft tissue, the status of the patient. Sometimes our soft tissue have contraction, or also sometimes the patient will have weakness in their soft tissue. But I think preoperative planning is a good tool to know the version, to know the inclination, and also to know if you wanted to need any bone graft or augment during the surgery. I would start with the how to do the preoperative planning with one of the template or with one of the companies that is available in our country. We have all of the companies have now the preoperative planning, so you can manipulate all of the knowledge now based on the company that you're going to use. First, once you put the CT scan in your computer or the computer that is have the available software, you have to ask your radiologist to do a DICOM cut, which is a thin CT scan cut, so you can do with a 3D images, so you can do your preoperative planning. Once you apply it and once you upload it in the system, it's going to appear like this in your system. In your system, before doing anything, you're gonna see the native anatomy of the patient on the left side of the screen. So we can see this patient in typical have a glenoid retroversion of 15 degrees. They also have a glenoid inclination of 3 degrees and also a posterior humeral subluxation of 67%. But You did not do anything. That's what the computer is showing to you. You're gonna have all of these parameters available for you. And then the patient name and all of the patient information, you're going to have it. And then with the AI, the software, it's gonna predict what you're gonna do. So sometimes you have a debate in your mind between going into a reverse shoulder arthroplasty or an atomic shoulder arthroplasty. I think it's a good hint that you can take. Sometimes it's a very very good tool. In this typical software, it's called the Blueprint. It's going to give you that the patient might end up with a reverse shoulder arthroplasty, and the probability of doing a reverse shoulder arthroplasty is more than 60%, which is, I think it's right for this patient. Then you can put your diagnosis, the glenoid type, and plan whatever you want. You want to plan an atomic, you want to plan a reverse, or you can plan hemi arthroplasty for the patient. Let's do a reverse shoulder arthroplasty and try to plan it. Once you click on a reverse shoulder arthroplasty, overall section in all software, it's not only for the Blueprint, you're gonna do your glenoid, then move into the humerus, and then check the range of motion or the joint by the end of the planning. I'm going to start doing the glenoid. The next screen for you is the glenoid. On the glenoid section, you can see that the humeral head was subtracted. If you want to have the humeral head with the glenoid itself, you can just click on the humeral head. I'm not sure if you can see my arrow, right? Can you see it?
Yeah, we can see that.
Okay, that's good. So once you wanted to have the humeral head with the implant with the glenoid itself, just you can click on it and then you can have it in your screen. But we want to plan glenoid, so no need for the humeral head right now. On the glenoid section, you can also choose your procedure, change your procedure. If you change your mind, you wanted to do like anatomic, you can just click on the top screen and then change it to anatomic. For now, I'm going to do a reverse. Then the implant of choice. The implant of choice, it depends on the company itself. It depends on the version that you are going to use. It depends on the type that you're going to use, the availability in your system or the availability in your country. For me, I'm going to use like Perform reverse shoulder arthroplasty. So that's overall image that you're going to see, the glenoid, then humerus, then we're going to go with with the joint itself. Then it's very important to check on the native anatomy of the patient. The native anatomy, it's also going to be shown in your screen, in the bottom side of the screen, that the diagnosis that you entered for the patient, it's a massive rotator cuff tear, but the system gave me that the patient has a retroversion of the glenoid 13 degree, and superior inclination of 6 degree, and RSA angle of 16 degree, and posterior humeral subluxation more than 60%. Now, why I'm saying this is important, because by the end of the templating, you can now know how much you correct during your or after your preoperative templating or planning. Then going forward, you wanted to template for the glenoid. As I mentioned, the implant is based on the implant of choice that you're going to use. I'm going to use a Perform reverse for the implant. Then build up your glenoid. How do you build up your glenoid? We start with the base plate. In the templating, you can choose your base plate. Is it a standard base plate or a base plate with an augmented or wedge base plate? For now, you have two options that you can choose of. The standard base plate, as you can see on the top image, and then the wedge base plate you can see on the right side. And then the diameter of the base plate itself, we have 25 base plate diameter, and we have a 29 base plate diameter. That you can also choose it during the templating or preoperative plan. Once you choose the wedge base plate, for me, I chose a wedge base plate because this patient has a posterior subluxation and also have some bone loss in the glenoid, mainly in the posterior superior. So the best option for this patient is to go for a wedge base plate. So I choose a wedge base plate. Then once you choose the wedge base plate, you can choose, is it a full wedge or a half wedge? A full wedge where you have the angle is completely complete during the from the beginning of the base plate until the end of it. And the half wedge, you can have it like a half, or if you have localized bone loss, you can use a half wedge base plate. Okay. And then if you have a glenoid deformities, what's your available option that you have to keep in mind during planning of doing a reverse shoulder arthroplasty, or how do you manage deformity of the glenoid? We have one option which we call a trim flat. You don't have to put a bone graft. You just have to eat more from the glenoid to make it just flat and put a standard base plate. You can have an augmented base plate. Augmented base plate, as I showed you, we have two options, full augment or half wedge. And then we can have a bio-RSA. Bio-RSA, where you take the bone graft from the humeral head itself and then shape it or plan it as you want, or based on the bone loss itself. And you can have the complex base plate, which is the patient-matched implant. Patient-matched implant that you can order it before doing the procedure, like for 6 weeks, and then the computer will generate your base plate based on what's the parameter of the patient itself. So we call it patient-matched or patient-specific implant. These are the options. Then going into the augment itself, some of the shoulder surgeons will argue that sometimes they use a lateralized base plate, so they don't have to put an augment to build the bone graft. But knowing your implant and knowing how much of the each implant will gonna compensate for you is the key to have a better reverse shoulder arthroplasty. So for this reverse perform implant, we have a standard which will give you lateralization of 1 millimeter. We have lateralized +3, we have lateralized +6. But then in compared to the half wedge, you can lateralize up to 7 in compared to the lateralization of 3 millimeter. And then if you use a full wedge, you can lateralize up to 8 millimeters. So it's going to give you more of the lateralization, and you're going to compensate for the bone loss in the glenoid. But we have challenges in each and every base plate or augment that you're going to use. If we use the base plate augmented, sometimes in your country or in your city, you don't, or in your hospital, you don't have the option for the base plate augmented. So you can do bio-RSA, but it's a limited option. Reaming are required, so more of the bone loss it's going to happen, or not it's going to happen. You have to do it so you can put your augment, or it has to not match the glenoid to augment. Sometimes the bone loss that you have it in the glenoid, it's asymmetrical, so you cannot put more of the augment to have it 100% seating or 80% seating. And on the other side, when you put the bio-RSA, which is the bone graft that you take it from the humeral head itself, have also some challenges that require the graft harvesting from the humeral head. Sometimes the humeral head is also deformed, so you can't take it from the humeral head itself, and the quality is the concern for that. Then going back, knowing all this, going back into your glenoid, building your glenoid, it has to be based on what's the option that you want to work with. For now, this patient has a posterior bone loss, posterior superior bone loss. So I put for the patient 25 base plate diameter, because this patient is a female. So in general, small patient, we're going to use 25 base plate. Larger patient, we're going to use 29 base plate, because 25 is a perfect fit for the glenoid itself, for the smaller individuals. So for this patient, she's a female, so I'm going to use 25 base plate. I'm going to use full wedge to compensate for the bone loss. Then the fixation for the augmented that I wanted to use. So if I use a central screw, it's going to be perfectly fit in the glenoid vault. But then if I use a central post, You can see with the base plate, with the planning itself, sometimes it's going to show you with the red. Red means it's very, I'm not going to say it's wrong, but there is something wrong. Maybe you're going to perforate, or maybe you don't have enough wall to have the post. So post mainly, you're going to use it with once you plan to do a bio-RSA or patient-matched implant. Then that's the option that you're going to use post. Or if you use the screw and then you perforate it, or it's loose, then you can use post. So leave the post as a second option, not the first option when you plan for the reverse shoulder arthroplasty. So the options for the central screw going down, we have 6.5, we have 9.5. 6.5 central screw, 9.5 central screw. 6.5 has a good purchase almost all the time, but sometimes, with especially in an osteoporotic patient, sometimes I find it looser. So I took 9.5. Not always, but sometimes you have this option. So it's good to ask your company rep to prepare for 9.5 screw available in your set. And then going back, so now we build the base plate itself. Knowing all of this, we have to build the base plate. Then I'm going to go to glenosphere. For the glenosphere in general, for the companies, it started from 33 to 42. But for the Perform or for the Blueprint in Tournier, they have the option of 36, 39, and 42. 36, usually we use it for a female patient or a smaller individual. Once we use a 25, it's better to use 36 with it. 42 or 39, 39 or 42, you can use a 25, a 29 base plate, and for a larger individual, like a male patient. So that's a general concept. Smaller individual, 25, 36. Larger individual, 29, 42. 39, 42, and 29 base plate. If you're in between two sizes, sometimes we have a larger female, or the vault for the glenoid is bigger, so you can use 39 if you're in between two sizes. In this case, another case, like this patient, male patient with rotator cuff arthropathy. So I used wedge implant, 25 diameter, full angle, fixation with the central screw. The diameter of the screw is 6.3, 6.5. And then the length of the screw, even you can know the length of the screw preoperatively with the templating itself. So for me, I like to have the screw is just a little bit penetrating the anterior cortex. So you can have a good purchase during screwing the base plate in the glenoid itself. And then I'm going to use 42 glenosphere and centered glenosphere. Why the type here centered? Because one of the options for the glenosphere is to have center or eccentric. Eccentric will give you more inferior glenosphere, or hanging more inferior, so the notching will be less and you can distalize more. So for this case, I think it's perfectly fit. Why I'm saying that? Because if you can see my arrow, that the full wedge is touching the glenoid itself. The screw is almost penetrating anterior. The screw length is good. And then I am putting it as inferior as possible. Okay, and the glenosphere, no need for the inferior eccentricity, because in general, having the glenosphere hanging 5 millimeter from the end of the glenoid will decrease the risk of scapular notching. Then we're gonna go for the this part, which is the most surgeon would be not difficult for them, but it's more confusing for them to do this part. But I think it's very, very important. Okay. How do you do your base plate or the glenosphere in the center and not perforating, having a good inclination with a perfect virgin, and also have a seating perfect? By knowing all of this parameter, you can build up your glenoid. The virgin, in general, it has to be less than 10 degree of the glenoid implant retroversion. During implantation of the, or during templating, you can increase the antivirgin by clicking on this part, or you can do the retroversion or posterior retroversion. So in general, the virgin is better for you to do less than 10 degree of glenoid implant retroversion. And then in the second option, we have the medialization. No medialization more than 1.5 millimeter. And why is that? Because if you medialize more than 1.5 millimeter or 1.5 millimeter, you're gonna take more from the native bone. So if you take more from the native bone, the risk of the fracture is higher. You're gonna end up with low volt with low stock, bone stock. So it's going to be very difficult for you to purchase the base plate on it. And then the seating is at least 80 to 90% of implant seating. And the seating, you can decide it by this one. It's 97%, which I think it's perfect. And then for the inclination, you can decide the inclination by this part. It's important to have an inclination less than 10 degree of superior inclination. We always aim for 0, but if it's less than 5, it's good. But sometimes you can accept, in general, less than 10 degree of superior inclination. And as I mentioned, the base plate placement, it has to be as an inferior edge of the glenoid. If you come up with this templating and this slide, it's going to be more than enough for you to build up your reverse shoulder arthroplasty. And then, as I mentioned, it's very important to pay attention of the screw trajectory to avoid posterior direction due to the risk of the scapular spine insufficiency fracture and the suprascapular nerve injury. So how do you know the screw penetration? By knowing the trajectory on the axial cut. This part is an anterior and this part is posterior, so it has to be within the anterior bolt. If I continue to do longer one, it's going to be more anterior. It's very bad to have the screw like this, which is posterior. So the risk of the fracture is higher, especially for older individual and less bone stock. Okay. Do you have any question on the glenoid?
No, please go ahead.
No, not yet.
Okay. Once you move on, you build up your glenoid and you're happy with it, so you can save. There is a button here, save progress. Then you can move on into the humerus. And the humerus is more simpler than the glenoid itself. You can use, as I mentioned, you can use here the reverse or the anatomic total shoulder arthroplasty. You can use your implant. You want your implant as an onlay or you want it as an inlay. Inlay is called perform stem, and onlay is called perform flex. We don't have yet perform or tournier. We don't have perform stem in Saudi, but we're gonna have it soon. But now we're gonna do the onlay. Okay, onlay that we have it, the tournier flex. In the humeral stem, you can see the neck shaft angle. I'm gonna go one slide. What's the importance of the neck shaft angle and the reverse shoulder arthroplasty? Neck shaft angle is based on how the implant is lateralized or medialized in your decision. So 155 degree is the original Grammont style, where they implemented the reverse shoulder arthroplasty to have a medialized glenoid and to have a medialized humeral stem. But then the problem happened because the patient will have more of the scapular notching, more of instability, more of dislocations. And then they implemented another degree of the neck shaft angle, which is 145. 145, we have different implants available in the market that they're using 145, which is the medialized glenoid and lateralized humerus. So if you wanted to do lateralization, you have to do it through the humerus itself. And then the latest update in the reverse shoulder arthroplasty, which is both lateralization, lateralized glenoid and lateralized humerus. Having this option with lateralized glenoid and lateralized humerus will make the implant more stable and less scapular notching. For this implant in specific, tournier flex, we have it in 145. We don't have tourniquet flex and only with 135. It has to be an inlay to have it lateralized. Okay, so I'm gonna go with 145 degree. Why it's important to what's the concept of lateralization? Lateralization, once you have the lateralization, is your center of rotation is lateralized during implementation. Because if you medialize your center of rotation, then the range of motion will be less, then the notching will be more, and the instability will happen more. And what is lateralization? Traditional, as I mentioned, Graham style has the center of rotation is more medialized, as you can see the dot arrow and the medial glenoid. But then the risk, as I mentioned, of instability is higher because all of your rotator cuff or all of the soft tissue around your implant is loose. So it's not going to hold your implant in a desired position. So it's going to shorten your external rotator muscle. This is a very well known concept. That's the reverse shoulder arthroplasty prosthesis design classification system. As I mentioned before, medialized, that's the original Grammon, then lateralized, then the 145, which is medialized glenoid, lateralized humerus, then 135, which is lateralized glenoid, lateralized humerus. Why it's very important to have a lateralized implant in a reverse shoulder arthroplasty? Because first, it's going to decrease the notching. And then it's going to increase adduction range of motion. It's going to improve your rotation because as we all know that the rotation is very hard to achieve full rotation with the reverse shoulder arthroplasty because of its designs itself. So it's going to improve your external rotation and internal rotation. It's going to improve your shoulder contour itself. It's going to improve your stability and improve your cuff tension. But then there is a cons for that is having it more lateralized is that you're going to increase your deltoid load. So the patient will have a slower recovery and it's going to increase a base plate shear and increase the acromial stress fracture. And in an elderly patient, we're seeing it right now more with the lateralized implant. We're seeing a lot of acromial stress fracture post-op. So we have to choose our implant carefully based on the patient also bone condition. Going back into the humerus stem itself, now we have to do the resection site. Resection site has to be just below the GT, just below the GT area, and below the curve in the lateral aspect of the humerus itself. So in the inclination, if you're going to do a reverse, it's built in B, number B, which is 132.5 B stem. And then I'm going to use a standard stem for the patient with the size 3. How do you look for this? Sorry. I resected this part, just a second. So you can choose your stem size based on this image in here. If it's more than 3, you're gonna see it here as a red. It means there is a risk of a fracture or risk of perforation or overstuffing of the canal itself. So for now, I choose the size 3 here. And then polyethylene insert, I'm using a standard polyethylene because I did 42 on the glenosphere itself, and I did a bone graft. So I'm pretty sure that I lateralized more. And then you have to pay attention on this part. This part is, it's going to tell you where you dilate your polyethylene. If you dilate it into 6, it means you're lateralizing much more. If you dilate into 12, it means you're going to medialize much more. So this one, you can do it and decide later on what's the best for you based on the range of motion in the joint itself. Then in the last part for this preoperative planning, it is the joint range of motion. I know that the joint range of motion is not 100% reliable, because we're eliminating the soft tissue itself, but it's going to give us an advantage, and it's going to give us provisional visualization of what you're going to face or how do you correct your mistakes during preoperative planning. For example, During range of motion, you're going to see if there is any notching. You're going to see if there is any impingement. You're going to see if there is any osteophyte that it's going to be in your range of motion field. So you have to take it off. So I think it's very important to know it, but not stick to it 100%. It's not going to be 100% as it is that the patient will have post-op, because we're not doing a soft tissue, and we all know that the soft tissue is very important role in the preoperative planning. So if you can remember that the patient virgin, it was 15. So we corrected the virgin almost to 0. Inclination before, it was up to 16, I think, and we corrected to -2. So it's compensated. And then in the arm changes. So this is very important, the arm changes. Why is that? Because you know that the lateralization for the patient post-op is going to be 2 millimeter, which is acceptable up to 5 millimeter. And the distalization is 34 millimeter. I think it's a bit higher than the desired one. They always mention it has to be up to 30 millimeter of distalization. And then it's very important feature in the preoperative planning, knowing what is your osteophyte that you're going to take it. So you have the option in the preoperative planning to remove your osteophyte, and by doing that, you know what is exactly, and take it off intraoperatively. Look for any osteophyte and remove it. And then that's the range of motion that we are aiming for. The adduction 40, abduction 60 to 70, internal rotation over 90, external rotation over 40, extension from 80 to 90, and forward flexion 120. I think we're almost achieved that during this range of motion. And why I'm saying that? Because there is a video that's going to show you how the patient's going to do range of motion without any impingement. If there is any impingement, there's going to be a red dot, exactly where is the site of the impingement, then you can correct either through the glenosphere, either through the lateralization, either through the distalization, or even you can resect more from the humeral head itself. That's the final images that you're going to receive. Your glenoid, your lateralization, your distalization, your range of motion, how you're going to see it intraoperatively like that, and the distalization and like this. And then by the end of this, you can generate your guide. Generate your guide. There is an option in the preoperative planning to give you the glenoid itself, and there is a dot in the center of the glenoid to show you what is exactly you're going to put your center screw. So I think this is very important, because sometimes you have a smaller bolt, so you don't know where it's exactly you're going to go anterior, going to go posterior. The perforation, it's going to be very narrow for you. And then this is your implant. I always print my my blueprint and just put it on the screen, or just I bring my laptop during the surgery and make it open for even for the nurses to know, and like give me the implant with the also the company rep. I always communicate with my company rep before time, making sure all of the implant is available for you. And as I'm saying, all of the surgeons that are using preoperative planning saying more than 90% of their preoperative planning is accurate and or similar to what they anticipated, or at least if there is any difficulties, makes it even better for them to know what is exactly your difficulty that you're going to face and try to solve it intraoperatively. Thank you. If you have any questions.
Thank you, Adeeba, for this detailed presentation. Adeeba, let's have some questions. Yeah. You can stop sharing, Adeeba.
Sharing. Okay.
Yeah. Thank you, Adeeba, for this detailed presentation on pre-op planning. I mean, you've gone step by step into almost everything, right? So, a few questions, Adeeba. Now, Adeeba, I just want to bring your notice to two papers that were published in Journal of Shoulder and Elbow 2021, Brandon Erickson. Okay. And one of the reasons he said that they looked at 4 different pre-op planning softwares, around 81 patients, 4 fellowship trained surgeons, And they found that there was some disagreement between what the pre-op planning software gave and what the surgeons found intra-op. And even they were recommending that the surgeon should be cautious when using commercial software planning systems and when comparing publications that use different planning systems. So what's your take on that?
So my first answer is that we're all human. We made mistakes. The thing is that we're going to keep it in mind, as I mentioned, and I will always repeat that sometimes you cannot anticipate what's going to go intraoperatively. Sometimes the patient will have a fragile bone, so the fracture will happen. Then you're going to shift into the fracture stem or a fractured glenoid. So what will happen and the difficulties with the soft tissue, you cannot just ignore it and go directly with what you're planning to do. And for the commercial, I think it's very important to have a preoperative planning. It makes your life easier. If you're not going to use it, at least you're going to know what is your osteophyte, at least. Where is your osteophyte and where can you take it off? Sometimes it's not going to be showing in your CT scan or so showing in your X-rays, or where is exactly your bone loss. We do the CT scan before like 6 months, and then after 6 months things are going to change, right? So I think having a preoperative planning, for me at least, and how I train, I think it's very essential. I would advise everyone to do it. At least it's going to give you an image. If you have like an image overall of what you're going to face, that's a take on it.
Great. So can we put it in a different way? Okay, it's a must to have a good pre-op planning, but you can expect some deviations from what the computer provides you. Am I right?
Of course. Yeah, of course. Yeah, I agree. 100%.
Yeah, you don't take it completely.
No. I'm not going to say you have to take it completely. No, there will be some changes with all of this. You're going to change what you're planning to do because there will be some difficulties intraoperatively. Like, for example, if I planned to do a central screw 6.5, I am 100% sure that this patient has a good bone stock. And intraoperatively, I was surprised that's not going to hold. Even 9.5 is not going to hold. And we faced it. So you can take it off and you put a post. So now I changed what I planned to do, right?
So what would be your concerns? Is it with version or inclination? Is there a concern with that? When you compare with the pre-op planning software, do you think your version or inclination would be in comparison with that? Or are you worried about the screw lengths comparison with the software?
No, to be honest, I'm more into not the screw length. I'm more into the version, the inclination, and how I'm going to build the bone graft.
Great.
That's what I'm like focused on during preoperative planning.
Thank you, Adeeba. That's what I wanted from you. Thank you so much. Before, I would also like to introduce you. I'm sure you know Loy Al-Khatib. Loy is a orthopedic sports surgeon and now arthroplasty surgeon as well, practicing in Dubai. Loy, welcome to the show. Any questions to Adeeba?
Thanks, guys. Thanks, Adeeba, for the outstanding presentation. Really enjoyed it.
Thank you.
One thing also to mention is the CT scan or the scapular position. Okay, once you do the CT scan, when you change there's big studies now, big talks on that topic. So if there's a movement in the scapular position was not correct or accurate, even 10 degrees in scapula might change you plus minus in the glenoid version. What does that mean? Does that mean when they need to take the CT scan should be perpendicular to the glenoid perpendicular to the scapular body. So in that way, to give you more accurate assessment of the version or the parameters of the glenoid. This is something we need to talk about. So not every CT is a valid CT to be used for preoperative planning. The other issue, I wish that Blueprint, especially this company, is the one that I did my fellowship with in Canada. If they add one parameter, is the depth of glenoid reaming. So some software gives you an idea how far you need to ream into the glenoid before you reach the original bone. This gives you a simulation. In that way, will give you more sensation, will give you more sense or more idea when to stop reaming for the glenoid valve. Okay, exactly. It's just small comments. My question to Adeeba, we have a perfect plan. We have perfectly planned everything. We printed out, handed out. But sometimes in cases of revision surgery, big patients, stiff shoulders, we're not able to execute these plans. So any tips? I think the answer you will note by yourself. Any tip just to perfectly execute these plans?
I think it's perfect to excuse this plan is to have a good communication with your company rep, to have all of the available anticipated implant that you're going to use is available in the table. So sometimes I'm planning to do a standard, and then I go there. It's more than there is a great bone loss, so I have to build it up. So I have to communicate with them to provide me with an augment, right? And then if you cannot do it with the preoperative planning, you can always go back to your original preoperative planning that we're doing it like back in the days, which is the X-rays, CT scan, and also MRI. I think we should not ignore the importance of all of this, but I'm just saying that this is an example of how to do the preoperative planning and execute it intraoperatively.
One thing to add is exposure. What I meant my question is that most of these problems, we have the glenoid malposition because of the poor exposure, especially in these challenging cases.
Right.
So one single advice to someone who's started to implant these reverse shoulder arthroplasties is to have a really good exposure. All the mentors, all the giants, George Athwal, Peter McDonald, Scott Sigmund, all these guys are emphasizing to have a great exposure of the glenoid. So in that way, you will be able to execute your plan without any difficulty.
Yeah, I agree. And one point on the CT scan, every company has its own protocol to follow. So you can just hand it to your CT or radiology department and then tell them that if I wanted to plan a CT scan or ask for a shoulder CT scan, that's what we're doing in our hospital. I'm just calling them to provide me with a CD, the same protocol that we're using it for this preoperative planning.
Exactly.
So every company, every company has its own protocol on how to handle the arm during CT scan.
Agree.
Thank you.
Awesome. Thanks.
Any more questions?
No, I think that's it for.
Thank you, Adeeba. I think that's all the questions that we have for this session. Thank you for this wonderful presentation. And
thank you so much.
Yeah, and we really look forward for more from your side.
Thank you so much. Appreciate it. Thank you.
Bye-bye.
Thanks, Adeeba. Bye-bye. Cheers.
Thank you.